Most people are doing everything wrong when it comes to knee pain. And I don't mean a little wrong. I mean the exercises your physical therapist gave you, the stretches you found online, the rest your doctor told you to take. For a lot of people over 50, those are making things worse. Not immediately, slowly, quietly, until one morning you try to get out of bed and your knees simply refuse. I want to show you something different today. Something that comes from a place most Western medicine hasn't caught up to yet. My name is Dr. Kenji Watanabe. I've been a sports medicine and orthopedic rehabilitation physician for 41 years, trained in Osaka, Japan, and later at Johns Hopkins in Baltimore. I specialize in what happens to the musculoskeletal system as it ages, specifically what happens to knees. I started making these videos because of a patient I saw about 12 years ago, a 67-year-old retired schoolteacher named Mrs. Haruko Ishida. She came into my clinic walking with a cane, barely able to climb the 2 steps to my office door. She'd had knee pain for 6 years. 6 years of ibuprofen, 6 years of knee braces, 6 years of being told she'd need surgery eventually. She was preparing to give up hiking, something she'd done every single weekend for 30 years. I didn't give her surgery. I gave her one exercise. One. And I made her do it every morning before she got out of bed. 8 weeks later, she walked into my office. No cane. I think about Mrs. Ishida a lot, because she isn't rare. She's actually exactly who most of my patients are, and almost all of them were told the same wrong things for the same long years before someone finally looked deeper. Here's what most people believe about knee pain. They think it's a joint problem, bone on bone, cartilage wearing down, something structural that needs something structural to fix it. Injections, surgery, bracing. And for some patients, that's true. But research published in the New England Journal of Medicine found that for the majority of adults over 50 with chronic knee pain, the structural damage visible on MRI doesn't correlate with the level of pain experienced. Read that again. The damage in the image doesn't match the pain in the body. That means the pain is coming from somewhere else, something the image can't see, and that changes everything about how we treat it. Think of your knee like a suspension bridge. The cables on either side aren't just decorative, they're the entire reason the bridge holds. If the cables on one side go slack, the bridge tilts. The central structure carries weight it wasn't designed to carry. Eventually it cracks, not because the bridge itself was flawed, because the cables weren't doing their job. Your knee works the same way. The muscles running along the front and inner thigh, the quadriceps and the VMO, which is the teardrop-shaped muscle just above your kneecap, are your cables. When they weaken, which happens naturally and rapidly after 50, the knee joint carries the full load. The cartilage compresses unevenly. The bursa, the fluid-filled sacs meant to cushion movement, becomes inflamed. The joint space narrows, and every step you take is a little wrong. The pain isn't the problem. The pain is the symptom. The weakness is the problem. Now here's the part that stops my patients cold when I explain it. Most people, when their knees hurt, stop moving. Completely logical response. Movement hurts, so they rest. But inactivity after 50 causes muscle atrophy at a rate of 1 to 3% per month according to data from the Journal of Gerontology. That means 6 weeks of reduced activity can cost you close to 15% of the muscle mass supporting your knee. The joint gets less support. The pain gets worse. So they rest more. The muscle weakens more. The pain deepens. I always explain it to patients this way. It's like tightening a loose screw by removing the screwdriver. The logic feels right. The result is the opposite of what you need. The single worst thing you can do for a painful knee over 50 is nothing. But, and this is important, the second worst thing is the wrong exercise. High impact, poor mechanics, movements that load the joint before the supporting muscles are ready. That's where most rehabilitation programs fail people. They jump too fast, too hard, into strengthening without first retraining the neuromuscular pathway, the brain-to-muscle communication that tells the VMO and quadriceps when to fire. And that brings me to the exercise. Before I tell you exactly what it is, I want you to do something. Stop for a moment. Think about when your knee pain hits hardest. Not during a long walk necessarily, though it's there. I'm talking about the moments that catch you off guard. Is it when you first stand from a chair? Is it on stairs, and specifically going down, not up? Is it in the morning, those first 10 or 15 steps before your body warms up? When the joint feels like it's been filled with wet sand overnight? Type yes in the comments if any of that sounds familiar, because I want to know how many of you are experiencing this specific pattern. It tells me a lot about where the breakdown is happening. Those morning symptoms. Let me stay with those for a second because they matter diagnostically. When you're still at night, synovial fluid, the natural lubricant of the knee joint, becomes less evenly distributed. The joint essentially stiffens. In a healthy knee with strong surrounding musculature, this resolves in minutes. But in a knee where the VMO has weakened, where the joint is carrying more compression than it should, those morning steps feel like grinding something that hasn't been oiled in weeks. Some of my patients describe it as walking on broken glass. Others say it's a deep ache, almost like the bone itself is tired. It doesn't wait for you to be ready. It hits before your coffee, before you've even fully woken up. That timing is the body's way of showing us exactly what it needs. The exercise is called the terminal knee extension. In Japan, we sometimes call it Hiza no kakusei, literally, the awakening of the knee. It has been used in orthopedic rehabilitation in Japanese sports medicine for decades. In Western medicine, it's known but underused and almost never prescribed as a morning protocol in the specific way I'm about to describe. Here is why it works. The VMO, the vastus medialis oblique, that cable muscle, doesn't activate the same way as the rest of the quadriceps. It fires at the very last 15 degrees of knee extension, that final moment when the leg locks straight. Most exercises skip right past that range. Most stretches never touch it. But that is the exact range where the kneecap tracks correctly, where the joint space equalizes, where the compression distributes properly. If that 15-degree window is weak, and in most people over 50 with knee pain, it is, the knee is misloading with every single step, every stair, every time you stand from a chair, every morning walk. The terminal knee extension trains exactly that range and nothing else. That specificity is its power. Here's how to do it. And I want you to pay close attention here because technique is everything with this one. You'll need a resistance band, light to medium resistance to start. Loop it around a fixed point at knee height, a table leg, a bedpost, a door handle. Step into the band so it sits just behind your knee and stand facing the anchor point. There should be light tension in the band, pulling your knee slightly forward into a very gentle bend. From that position, you are going to straighten your knee fully, completely, until your leg is locked. Then slowly, and this is where most people rush, slowly release back to a soft bend. Not a deep bend, just soft. That's the full movement. Slow, controlled, complete at the top. I want you to do 15 repetitions, then rest 20 seconds, then 15 more, in the morning, before you walk anywhere, before the first steps that usually hurt. You train the VMO before you ask it to work. A study published in the Journal of Orthopaedic and Sports Physical Therapy found that isolated VMO training through terminal extension reduced anterior knee pain in over 70% of patients within 6 weeks. 70%, without surgery, without injections, without any change to medication. That number didn't surprise me. I've been watching it happen in my clinic for 4 decades now. This is the part where I need you to stay with me, because what I'm about to tell you is something most people are never told. The terminal knee extension alone is powerful, but what makes Mrs. Ishida's recovery, and the recoveries of the thousands of patients I've treated, sustainable is what happens immediately after the exercise. Gentle, loaded walking, not a long walk, not an intense walk, 3 to 5 minutes, immediately following the exercise while the VMO is activated and warm. Slow pace, flat surface, no incline. Here's the mechanism. The exercise primes the neuromuscular pathway. The brain to VMO signal is live and firing. When you immediately walk on it, You are training the muscle to fire correctly during the movement pattern it needs to support. You're not just building strength, you're rebuilding the habit of the muscle. Think of it like waking up a sleeping employee and immediately giving them a task. They're sharp, they're present, the work gets done right. Versus doing the exercise and then sitting back down, which is like waking the employee saying good morning, then sending them home. The moment passes, the signal fades, the knee goes back to its old pattern. The sequence is the protocol. Exercise, then walk. Every morning. I want to come back to Mrs. Ishida for a moment. When she first came to see me, she said something I've never forgotten. She said, "I think I waited too long. I think I've ruined it." She hadn't. But I understood what she meant. Not just the physical fear, the fear that the body has crossed some point of no return. There's something else underneath that fear. The quiet weight of wondering what else you missed while you were waiting. What hikes you didn't take. What mornings you sat still instead of moving because no one gave you something real to try. That's the part I think about when I make these videos. Not the clinical outcome, the years between. One more thing I want to address because I hear this constantly. "Dr. Watanabe, I've had x-rays. My cartilage is gone. Is this still for me?" Here's what I'll say. Cartilage does not regenerate meaningfully in adults. That's true. But cartilage damage is not the only source of knee pain, and in many cases it isn't even the primary one. Research from the British Medical Journal found that patients with identical cartilage damage on imaging can have wildly different pain levels based on the strength of surrounding musculature. One patient barely functions, another runs marathons. The difference is the cable system. If you strengthen what holds the joint, you reduce the compression on what's damaged. You change the load distribution, you give the joint the support it never had. The cartilage doesn't grow back, but the pain very often retreats. That's not a miracle. That's basic biomechanics. That's what happens when you fix the cables on the bridge. If you've been watching this and nodding along, if the morning stiffness hit home, if the chair-to-standing moment feels familiar, if you've been living around your knee pain instead of through it, I want you to try this. Tomorrow morning, before the first steps, resistance band behind the knee. Face the anchor. 15 extensions, slow and full. 20 seconds rest. 15 more. Then 3 minutes of gentle walking. That's it. That's the protocol. Give it 6 weeks before you decide anything. 6 weeks of every morning. And then tell me what changed. If you know someone living with knee pain, a spouse, a parent, a friend who's given up something they love because their knees won't cooperate, share this video with them. Right now. You don't have to say anything, just send it. Let them watch. You might be giving them back something they thought was already gone. And if you want to learn the second and third morning exercises I add for patients once they've mastered the terminal extension, the ones that target hip stability and posterior chain support, I'll have those in the next video. Together, the 3 make a complete morning protocol that takes less than 12 minutes total. But start here. Start with 1. Done well, done daily. Mrs. Ishida hikes every Sunday. Don't wait as long as she did.